Okay, welcome back. So we're going to learn about altered hormones, endocrinology, which is in chapter 13, and then that continues in chapter 20, which is with a specific focus on diabetes. So hormones are essentially chemicals that are formed in either tissues or organ systems that affect the growth or function of other target tissues and target organs. The hypothalamic pituitary axis in the brain is the primary control center for these hormones. Hormonal balance is managed through primarily negative feedback loops within the body, but there are a few hormones subject to positive feedback loops. Patterns of hormone secretion, metabolism, and elimination are predictable, and we can manage if there's an alteration. We can draw levels of those hormones and modify, make changes, or make adjustments based on what those levels are. And hormones have to locate and attach onto the receptors of target cells in order to be activated. And then they exhibit those actions on those target organs. The hypothalamic pituitary axis controls both synthesis and secretion of many hormones, and it does that through both releasing and inhibiting hormones. So here you've got the releasing hormones, growth hormone, which is important as you're growing and developing, thyrotropin releasing hormone. That's what kicks off the cascade that gets to your thyroid gland to release thyroid hormone. Corticotropins, you know, are involved in the stress response. Gonadotropin, which is involved in reproduction and sex hormones. And then we have inhibiting hormones, somatostatin, which will turn off growth hormone or thyroid stimulating hormone. And then also dopamine, which inhibits prolactin. Here you have 3 different examples of how hormones are released or promoted for release through the hypothalamus. So in example 1, which is talking about prolactin, prolactin is a hormone essential for lactation in female mammals, so milk production. Here the hypothalamus directly produces the hormone, and then it travels to the pituitary gland and then is released into the circulation. So direct production at the hypothalamic level. Example 2 involves growth hormone. Here the hypothalamus produces a releasing hormone. So the hypothalamus is not making growth hormone in this case. That releasing hormone travels to the anterior pituitary, and the pituitary is stimulated to produce and release that growth hormone into the circulation. Example 3 is thyroid hormone. Here the hypothalamus produces a releasing hormone. The anterior pituitary gland then is activated to release a stimulating hormone, and that stimulating hormone travels to the thyroid and encourages the thyroid to produce thyroid hormone. So 3 different ways in which that can happen. Most of the hormonal control systems are through negative feedback loops in the body. So negative feedback loops occur to either reduce or change the output. And your book uses a great example of a thermostat. In the house, when the temperature gets too hot, the thermostat shuts down and stops turning out heat. When the temperature is too cool, the furnace kicks back on to release heat. So thyroid hormone, if you have enough circulating thyroid, that information gets back to the brain. The brain will shut down or decrease thyroid stimulating hormone, and then less thyroid will be produced. If your thyroid levels are too low, that will stimulate the brain to release more thyroid stimulating hormone, and then the thyroid gland will churn out more thyroid. So these are the most common control systems in the body, are the negative feedback loops. So on and off controls to change the system and get back to homeostasis. Okay, so what do we think of when we see this image? Personally, it gives me a little anxiety. I can feel my fight or flight system, being activated. So you have two options here. You can stay and fight off this saber-toothed tiger, or you can flee, right? And we have this really incredibly complex, elaborate, and rapid response system that is built to keep us alive. It's a survival mechanism. And if you've ever interviewed someone or talked to someone that did something heroic under incredible stress, sometimes they'll say, I don't even remember what happened or how I did it. I just jumped into action. And that's because this system is designed for survival. So you may not be thinking, you may not be using your frontal lobe to make, careful decisions. But your stress response takes action for you. So it's a great system. And, I guess the trouble today is that we have multiple threats without the opportunity to discharge all the energy that comes with it. So let's go to the next slide and we'll talk about the hormones involved in the stress response. As part of our survival technique, our brain, our eyes, we're constantly surveying the environment. And again, this was useful back in the day when there were a lot of perceived threats and we were maybe frequently preyed upon. So because of these survival instincts, our brain makes rapid decisions, sometimes even rash decisions. This is why I tell you guys before an exam to calm that nervous system down, because your brain really wants to make a rapid assessment and jump to conclusions. But here we are with our stress response. So there's a perceived threat. Fear is processed by your amygdala, and that signal is sent to the hypothalamus. The hypothalamus then releases corticotropin-releasing hormone that goes through the pituitary, and then that prompts release of ACTH. That's your adrenocorticotropic hormone. That works at the adrenal glands. And then the adrenal glands are what secretes cortisol, which is your stress response hormone. So remember, your fight or flight, your stress response is to preserve critical function. So you're going to have contraction of blood vessels. You're going to stop making urine, stop digestion. You're going to be hyper alert. You are going to, your heart rate will pick up, your respiratory rate, your lung capacity will increase, and you're going to release a whole lot of glucose from the cells into the body. And that's because you would need energy to fight off something or to run. That stress response also suppresses immune system function because, again, we don't have time for healing. We're not doing normal maintenance functions at the moment. Epinephrine and norepinephrine get released. Again, all part of that stress cascade. Okay. So now imagine if you're under a state of chronic stress and what that does to glucose control, anxiety levels, immune function suppression. think about the potential long-term sequelae of all of that. So Hans Sale was an MD and a PhD researcher who looked at stress, and he developed the stages of general adaptation. So this is essentially what I just described. In the alarm stage, that's your fight or flight system. Cortisol and other stress hormones are activated and elevated. If it's just a short-term stressor, then your body gets back to homeostasis pretty quickly. But if you have prolonged stresses, then you enter what we call the resistance stage. Here, cortisol and epinephrine remain elevated, as well as blood sugar. And here's where people start to feel the long-term effects with sleep issues and other health problems. And then the body eventually, if you're not able to regain homeostasis, can enter a stage of exhaustion or burnout from stress. And there we start to see symptoms of severe fatigue, poor sleep, and then immune system dysfunction. So prolonged stress, long-term activation of your stress response can disrupt almost all of your body's processes. And we have special concern for cardiovascular health, immune system dysfunction, and then the connection between neuro and psych disorders. And, you know, I can't stress enough that psychological stress will manifest in the physical, and physical stress, pain, etc., can manifest in the psychology of the brain. You know, these things are not separate. They're very intertwined. You can have anxiety, depression, etc., that manifests in physical illness. And there's just a deep, deep connection between the two. So this is why when you're under a lot of psychological stress or duress, we recommend doing something physical to discharge some of that energy, whether that's going for a run or a walk, having time with nature, doing something really physical to help with that. Here's just a list of different factors that affect your ability or your patient's ability to adapt to different stressors. You know, you may have low physiologic reserve, you know, if you have chronic underlying health conditions that really impact your daily life, and then you have new acute stressors superimposed upon that. Your ability to manage the stress will be different than someone who at baseline is happy and healthy. Genetics, age, gender all play a factor into adaptation. Your nutrition and sleep patterns, and then psychosocial factors, and what, you know, maybe how you live, how you were raised, how you've grown up. I think about populations that I work with that are refugees. I mean, they've undergone lifelong stressors, so their adaptation skills and styles will be different. So anytime you're working with a patient, you have to be sensitive to where they're coming from, right? Something that might work for you and I might not work for them, or you'll meet patients that have different willingness to try new things to maybe help manage or cope with their stress. At the end of the quarter, when we talk about pain also has a lot to do with your ability to adapt and cope. And so being able to manage stress, you can actually reduce pain, physical pain, by quite a lot. So I think learning some of these skills and how to help your patients navigate this will help you in your future as a nurse. Okay, now let's get into the pathology of hormone function, hormone disruption. So there's 3 ways that you could have dysfunction or altered pathology. The first way would be if there was actual damage in the part of the brain affecting the hypothalamus or the pituitary gland. So damage to that HPA axis. And that can happen from infections. You could have a brain tumor, a hemorrhage, or a stroke that causes hypoxia. Hypoxia is probably the leading cause of cell damage and subsequent tissue and organ damage to systems within the body. So that's a big one because hypoxia can be caused from multiple different sources. And then we also have genetic defects. I had a patient this week who was born with an absent corpus callosum. That's a midbrain structure that helps left and right signals communicate from the brain to the body. So it wasn't the corpus callosum absence itself, but just that there were damage to midbrain structures and missing parts of the pituitary gland. So this particular patient had presumably alterations in a lot of hormone signaling. We're actually still going through the testing phase of different hormones in that patient's body, but genetic defect is one potential cause of damage to those areas. So the second thing would be damage to the gland itself. Whether you're talking about the pituitary gland or the thyroid gland or the adrenals, any of the glands in the body can be subject to damage. Most commonly, that's from autoimmune disorder or dysfunction, inflammation, chronic inflammation, and actually infection and inflammation can be a trigger for autoimmune disease in the body if the immune system doesn't recover. Hypoxia, again, is there. You can also have damage from radiation that disrupts the cells in that organ, and then genetic defects there too. And the third way that we see hormone disruption can be damage to the cell receptors themselves. Again, this can be from hypoxia, which is a common cause. It can be from antibodies or autoimmune disorder. You can have a lack of receptor sensitivity, usually from impaired enzyme or protein production, which could be a metabolic disorder, but could also be caused by hypoxia. And then you can have tumor cells that alter the receptors. So this box comes from the chapter, and I thought it was useful just demonstrating for you how we go through the process of identifying what's going on with a patient. So a patient would come in with maybe a handful of signs and symptoms that maybe they're not feeling well or have been not feeling themselves for a while, weeks, months. It varies depending on what's going on. And often with hormones, it affects so many different systems. So you have a wide range of symptomatology. I'm thinking about thyroid, for example. If your thyroid is low, you're cold, you're tired, you're putting on weight. Your heart rate might be lower, your blood pressure might be lower, you could have hair loss, thinning hair. So see how it's just a wide range of symptoms and very sort of non-specific, tired a lot, fatigued a lot, feeling down. I mean, we could easily attribute this to something else. So if a patient comes in, we start really broad with how we look at things and then try to narrow. With a patient like that, you might wonder if they're coming down with something, if they have like a viral illness. So you might start with your CBC, which gives you the white blood cell count and all of that information. And if there's nothing there, you just continue your investigation. You would look at electrolytes, and then eventually that would lead you to doing some hormone levels and looking at things. If in this example, thyroid hormone levels were abnormal or out of whack, we would then go to the most obvious. We would look at the thyroid gland itself, maybe get an ultrasound and see what's going on there. And then you just work your way kind of through these questions. If it's not the gland, is it something with the HPA or hypothalamic pituitary axis? You know, we may have to do some imaging of the brain, look at the stimulating hormones, things like that. So that is how that process goes. This little table is a great reference for you guys to look at what excess and deficit of each of these hormones would look like in terms of signs and symptoms that patients present with. So please do look at these. We are going to have questions about cortisol, growth hormone, and thyroid. So take a look. Okay, so let's take a look at the thyroid gland. The thyroid gland produces thyroid hormone, which regulates your metabolic rate and is critical for growth and development. So really important to have normal thyroid function in infancy and childhood as you're growing. And then it also maintains iodine homeostasis throughout the body. So this is just a short list of what thyroid function is involved in: stimulating metabolism, facilitating breakdown of carbs, protein, and fat for energy, heat, glucose production, cardiac output, muscle tone and reactivity, gastric motility, cognitive processes, and then growth. It operates on a negative feedback loop. So the hypothalamus will release TRH. That'll stimulate your pituitary to release TSH, thyroid stimulating hormone. And then that prompts your thyroid to release T3 and T4. So in the patient setting, if we had concerns, we would actually test TSH and T3 and T4 plus or minus calcitonin. A patient could have high TSH levels. That should prompt the thyroid to release thyroid hormone. But if something's wrong with the mechanism, say you have high TSH, but you don't have adequate T3 and T4 circulating, then that tells us that there's something wrong, not at the brain, not at the pituitary, but at the level of the gland. And we see that with autoimmune disorders, thyroid cancer, sometimes with Graves' disease. If you had low levels of T3, T4, but also low levels of TSH, so TSH is not being stimulated, then we would be worried that something's going on with the pituitary gland, and then we would look at that. Here's just another look at where that thyroid hormone is working in the body. You can see the brain, the eyes, lungs, heart, digestion. So if someone has low levels of thyroid hormone at the level of the brain, they're going to feel sleepy, sluggish, depressed. Eyes, they might have blurred vision, trouble focusing. A slower heart rate, so it lowers that whole basal metabolic rate. So slow heart rate, slower respiratory rate. It slows digestion. These patients often have constipation or gas buildup. We do see altered reproductive function. If someone has gone with low thyroid for a while that's undetected, they may be having trouble with fertility as well. And then in a developing human, like a child, we'll see effects on growth and development, so delayed growth and development. And then high levels of circulating thyroid, you have opposite effects. So at the brain, you would have agitation, anxiety. You would have a rapid heart rate, rapid breathing, hot temperature because your basal metabolic rate is higher. Those patients might have diarrhea because things are accelerated in the GI tract, etc. And these are just the thyroid hormones that we would test for. So on the left side of this slide, we have causes of hypothyroid or underactive thyroid, so low thyroid levels. And hypothyroidism is pretty common amongst populations. Autoimmune disease would be the primary cause of hypothyroid. We also see thyroid cancer, in rare cases, iodine deficiency. I say rare because foods, salt specifically, is now subsidized with iodine. So we don't see people, large populations, that are iodine deficient anymore. And then there is a congenital condition of hypothyroid. It's an inherited disorder at birth where they don't make enough thyroid. We actually do test for that in all live newborns so that we can replace thyroid hormone before development is delayed or altered. Then on the right-hand side, we have causes of hyperthyroid, so overactive thyroid. Graves' disease is the most common. It's an autoimmune condition, and it causes the gland to enlarge, and so you have increased number of cells at the thyroid level producing thyroid hormone. Thyroiditis is an inflammatory process, usually caused by different viruses, that causes increased production of thyroid. Goiter is an enlarged gland, and then you can also have thyroid nodules that are non-cancerous, so just growths that cause increased production of thyroid hormone. Thyroid disorder is 10 times more common or higher risk for females over males, often triggered by autoimmune disease. And actually, autoimmune disease in general is higher prevalence in females. Hypothyroid, that's the most common thyroid disorder. Hashimoto's thyroiditis is an autoimmune disorder, but you can also have hypothyroid from exposure to radioactive iodine. If you have had goiter or hyperthyroid and had surgery to remove that excess thyroid tissue, that can put you into a state of hypothyroid. And then congenital hypothyroid, like I said, and then a pituitary problem, which is rare, but we do see pituitary tumors that cause disorder in thyroid function. And here's the long list of symptoms of hypothyroid, which I've already discussed. Treatment for hypothyroid is going to be thyroid hormone replacement. It's dosed in micrograms. We generally start at a lowish dose and then titrate up. We can monitor levels in the bloodstream and make sure we're within the normal range. If there's thyroid cancer that's causing it, then of course we would need to remove any cancerous tissue surgically. They also irradiate thyroid tissue sometimes to kill cancer cells. And often it's more prudent to remove the entire thyroid gland to reduce the risk of cancer recurrence. So if that's the case, then the patient will have no thyroid gland and will require thyroid replacement as their only mode or method of getting thyroid hormone. But regardless, once you're on, even if you just have an underactive thyroid, if it's not cancer related, you're generally on that thyroid replacement for life once you start. Hyperthyroid, that involves excess thyroid hormone production and secretion with or without an enlarged thyroid gland. So if the gland is enlarged and you have a goiter, you have increased cell population there. More common in females. Also most common would be Graves' disease, which is an autoimmune disorder. Graves' disease is notable for something called exophthalmos, where the eyes actually appear enlarged and almost protruding. And then a palpable mass in the neck, so you can actually feel that enlarged thyroid gland. This can also be caused from pituitary tumors or thyroid cancer, and excess iodine supplementation can also produce hyperthyroid. And here are your signs and symptoms of hyperthyroid, which we have already talked about. So everything metabolically increased. Here are pictures of what radiology would look like when we look at the thyroid gland. So it's the gland in your neck has like a butterfly shape. You can see in that first picture, that would be normal uptake of radioactive iodine. So that gives us normal shape and size. You can see in the next picture, Graves' disease, that those glands are quite enlarged. And then the two bottom pictures are different types of tumors or adenomas, where there's clusters of increased uptake of that iodine. In the immediate period of treating Graves' disease, we may give the patient beta blockers to control symptoms. So remember, you've got accelerated heart rate, tachycardia, and that can be dangerous for the patient. So if you're waiting for them to get in for surgical repair, the provider may start them on a beta blocker to slow that cardiac rate down. There are some anti-thyroid medications, and then ultimately these patients end up with either surgical removal or radioactive iodine ablation, and that's to kill that excess thyroid tissue that's causing trouble. Okay, we're going to talk about disorder of the adrenal glands. So you know the adrenals are those little glands that sit on top of your kidneys, and they play a critical role in the stress response, right? So we had talked about aldosterone and renin-angiotensin system. Adrenals also secrete epinephrine and norepinephrine, so that's part of the stress response. But in addition to those mineralocorticoids, they are involved in glucocorticoids, so cortisol release and stimulation, and that regulates metabolism, inflammatory, and immune response in addition to the stress response. Your aldosterone, that regulates sodium, potassium, and water, right? We learned about that a lot, and blood pressure control. And then they're also involved in sex hormones, androgens and estrogens. So that contributes to normal reproductive growth, development, and function. Cushing syndrome is a condition that happens after prolonged exposure to elevated levels of your cortisol. So that can be either from the adrenal cortex, so maybe there's a tumor or something there that's causing excess tissue, excess secretion. But more often we see this with a patient that's on prolonged glucocorticoids. So imagine someone with a chronic inflammatory condition. I'm thinking of our pulmonary or respiratory conditions where someone would need to be on a prolonged course of steroids to help with breathing, which is obviously very critical, right? We want oxygenation. So prolonged exposure to those steroids can cause Cushing. And then what happens is you have metabolic alterations, excess circulating glucose, and then suppression of your inflammatory and immune response. Remember, with your fight or flight response, you release a rush of glucose into the bloodstream so that you have energy to activate. But with this prolonged exposure, such as in Cushing's, that glucose energy that's circulating is not being utilized. So what happens is you get fat production, mobilization of fats, and then these patients end up with obesity, extra adipose tissue to the face, trunk, their back, their abdomen, and then they develop glucose intolerance, so almost like a diabetic state because the tissue is not able to uptake all of that. They also prolong suppression of immune system, so they can have skin changes, risk for infection, and then they can also have emotional disturbances and an impaired stress response. Here's a picture of what that looks like. The picture on the left is from your textbook. The picture on the right is from a PEDS book. You can see the changes that occur. So it's a change that happens actually fairly rapidly. You can tell when your patient's being affected by prolonged steroid use. And there are a lot of congenital conditions where our kids need to be on steroids and then develop changes like this. Anytime we have a patient on prolonged steroids, we like to have baseline cortisol levels, and you can monitor that. But if they weren't on a steroid, a corticosteroid, and you were having symptomatology, then we would test that in the patient. You can do 24-hour urine collection. You can also do serum levels. And then if those were altered, then we would do ultrasound to look at the adrenals and see what's going on. Treatment for Cushing's syndrome is ultimately removal of the cause of that excess cortisol secretion. If we have the patient on prolonged steroid use, we always have to weigh the pros and cons of keeping the patient on that. But corticosteroids are not something that you can take off rapidly because the patients pretty quickly feel the pain of removal of that. I'm thinking specifically about my pulmonary patients who have so much inflammation and scar tissue in their lungs, and so the corticosteroid suppresses that inflammation. When you take that away, that inflammation can rebound, and then they'll have trouble breathing, pretty rapid decompensation in their breathing. So this is something that we wean away very slowly. We titrate down. If I have a patient on, say, prednisolone for pulmonary indications, I might wean that over 6 weeks. So again, not something that we take away quickly. And we have to always weigh the pros and cons. But ultimately, if they're suffering Cushing's syndrome as a result of that, you do want to get things down to the lowest manageable dose. And then if it's the cause is from a tumor or something else, then maybe there's a surgical procedure that needs to happen to remove tumors, chemotherapy, or radiation. On the opposite end of the spectrum, then, we have something called Addison disease. In my area, we just call it adrenal insufficiency. So here you have an adrenal gland that is not producing enough cortisol and aldosterone from the adrenal cortex. The most common cause of this is autoimmune destruction of the adrenal cortex. But this can also be seen with cancer. There are inherited disorders of the endocrine glands, and then more rarely hypoxia or traumatic brain injury. So again, with that HPA axis in the brain causing destruction or dysfunction, or a pituitary tumor. And then more rarely, tuberculosis can actually, the TB bacteria can attack and destroy the tissue in the adrenal glands and cause permanent dysfunction. So with adrenal insufficiency, the gland does not produce enough glucocorticoids. mineralocorticoids or androgens. So remember, that's part of your fight or flight response that keeps you alive in times of acute stress, and also management of sodium, water, blood pressure. So imagine if you don't have sufficient circulating hormone for that function. These patients can get in trouble very, very quickly. When the adrenals are not making enough hormone, that signal tells the brain to create and release more stimulating hormone. So these patients will have high ACTH unless the origin of dysfunction came from the brain. Okay, so with high ACTH, we see darker pigmentation of the skin. And that's because ACTH works in the skin melanocytes. So that creates a pretty telltale sign of skin darkening with Addison disease. So glucocorticoid deficiency, these patients are going to have a very poor stress response, hypoglycemia, weakness, fatigue, nausea, vomiting, weight loss, personality changes. And then with the mineralocorticoid deficiency, dehydration, hyponatremia, hyperkalemia, and hypotension, which can quickly lead to shock. Where I work, I'm working with a lot of critically ill patients. A lot of them have a history of severe or prolonged hypoxia. So I'm always worried about the brain. I'm always worried about the kidneys being affected. So if I have hypotension that I've treated, say they were hypovolemic, fluid down, and I've done all the normal things to bolster their total fluid volume, and I'm still having trouble with hypotension, my next thought is about the kidneys and those adrenals. So we're going to look at electrolyte levels. We're going to look at corticosteroid levels. And we can also administer ACTH, so that's your stimulating hormone. And if that does not get a rapid response in steroid levels from those adrenals, then I know that the dysfunction is there. So these patients, once destruction of those hormone-producing factories in the adrenals are gone, these patients need long-term supplementation or management of those steroids. So steroid, glucocorticoid, mineralocorticoid replacement therapy, if they are have returned to health and are at normal baseline, then we do what we call maintenance level dosing of these hormones, okay? Because you and I have a normal amount of steroid production that we're making every day for daily life. If these patients get sick with anything, or if they need surgery where we think there's going to be a big immune system response or stress response, then they may need stress dose of those steroid hormones. And so it's important to know who these patients are and to have that on our radar so that we can treat them preoperatively, for example. And you don't want to have a patient who's on baseline replacement steroid go to surgery and then come back hypotensive, and then you can't get on top of that low blood pressure. So lifelong replacement, unless the only case where sometimes we have a patient that had a transient adrenal insufficiency from hypoxia and then they recover. Those patients would not need lifelong treatment, but that's more rare. It's usually these patients have autoimmune dysfunction or something that takes it out permanently. And then because these hormones manage sodium and water, we have to monitor sodium levels and then have them do sodium replacement when they get home. Okay, so we are going to talk about glucose, insulin, the pancreas, and disorders associated with that. So you all know glucose is a sugar for making ATP or energy. It's the energy source for the cells in our body. And we get that from dietary sources, carbohydrates specifically, right? Any excess circulating glucose we store as glycogen in the liver. Glucose in the bloodstream triggers the release of insulin. Insulin is the anabolic hormone that takes that glucose and pulls it up into the cells, particularly liver, muscle, and fatty tissue or adipose. Insulin is not required for glucose uptake in the brain, red blood cells, kidneys, or the eyes. So the anabolic hormones, which include insulin, are responsible for building complex compounds in the body, building proteins from amino acids. And insulin has key functions, promotes glucose usage, and that decreases your blood glucose level, because when you're pulling that glucose out of the bloodstream, you're pulling it into the cell. Think muscle cell tissue. Again, if you were activating your fight or flight and you needed to run 10 miles away from this tiger, the muscle tissue needs energy. So your body would pull all of that circulating glucose into the muscle tissue. Insulin also promotes protein synthesis. It promotes formation and storage of lipids or fats, and then it facilitates transport of potassium, phosphate, and magnesium into the cell. Remember, potassium also in that cell, that's your energy source for that action potential. Within the pancreas, we have 3 types of cells. Alpha cells, those secrete glucagon. That's what is going to mobilize glycogen from your liver and suppress insulin secretion. So glucagon, that's what maintains your normal blood glucose levels between meals. Beta cells secrete insulin. Insulin is what promotes glucose uptake or glucose utilization. And then we have delta cells that secrete somatostatin and gastrin. And that regulates alpha and beta cell function by suppressing insulin, glucagon, and pancreatic polypeptides. So this is part of that negative feedback loop. Everything is balancing and ultimately to be in a state of homeostasis. So then we have disorders of the pancreas or disorders of the regulation of glucose in the body. Diabetes mellitus, there are 3 types. Type 1, which we'll go over in more detail, is an absolute insulin deficit. Type 2, insulin resistance or impaired ability of your tissues to use insulin, coupled with an insufficient insulin in relation to your body's needs. And then there is a gestational diabetes that happens sometimes in pregnancy, and that's insulin resistance as a result of too much hormone production in the body. Diabetes leads to a state of hyperglycemia, so high glucose levels circulating in the bloodstream, and an inability to transport glucose and amino acids into the cells. Then what happens is your liver, muscle, and adipose cells become energy deprived. So type 1 diabetes is quite rare, 10% of all diabetes cases. It was previously called juvenile onset or insulin-dependent diabetes mellitus. And here you have an absolute or significant insulin deficiency. So pancreas not making any insulin. So here we have delayed childhood development, inability for the cells to get energy, and a very, very ill-appearing child. And this generally happens around ages 10 to 14 is typically when it presents. So while this has a strong genetic component, there have to be triggers. So genetics plus environment. And often we see autoimmunity that's been triggered by a virus or a toxin. So some sort of inflammatory process in the body that triggers this, coupled with this genetic predisposition. The cell-mediated immune response targets beta cells, and attacks and kills them. And that's what, once your beta cells are destroyed, you're not able to produce insulin. What happens is the body turns to fat for energy instead of glucose. And then the patient moves into a state of ketoacidosis. So buildup of ketones making the blood acidotic, and they can be very, very sick. Onset of this disease is usually rapid or sudden onset, again, because it's triggered by some event, usually an infection or autoimmunity. So these kiddos get sick quite quickly and often have no underlying or no other illness. So signs and symptoms, they present with excessive thirst, excessive urination, excessive hunger, but usually what brings them in is fatigue and lethargy. So they're really, really not feeling well. They have blurred vision, they feel sick, and then upon testing you find that their blood sugars are very high, can be in the 200 to 300 range, and then hyperketonemia. So we test blood and urine for ketones, and that's how we get to this place. So diagnosis, history of recent events and signs and symptoms. We're going to check those glucose levels. We're going to look for ketones. And then we also have antibody tests, so we can look at whether your body's producing antibodies against those beta cells. And then hemoglobin A1C levels or glycosylated hemoglobin levels. You'll hear about this. It's important to know about throughout your career. This is a blood test that determines hemoglobin and red blood cell exposure to glucose over time. So it's a look back in what those glucose levels have been over the last 3 to 4 months, which is a great metric for us to look at whether your glucose levels have been under control or not. Because as you know, when you do a glucose check at the bedside, or in the clinic, that's just giving you one point in time. It doesn't give you the history of what's been going on in the body. So we combine those. We do fasting glucoses. We might do glucose checks post-feeding, like half an hour after food to see what your glucose and insulin levels are doing. And then that hemoglobin A1C, that gives us the history. So treatment for type 1 diabetes, the diet control is everything. These patients don't have insulin to help with uptake into the cells, so they are insulin dependent, and we have short-acting, intermediate, long-acting, and then often these patients end up with an infusion pump, which is nice because that's just an easier way for prolonged maintenance and management. So insulin is required in this case, and then close monitoring of your glucose levels and management of your protein, carb, and fat intake. And then once they're on insulin, exercise for all diabetics, it increases glucose uptake into the cells. So diabetic ketoacidosis is a rare but life-threatening condition that can occur in type 1 diabetics who don't get insulin. They develop severe hyperglycemia and metabolic acidosis, and then severe osmotic diuresis. So often triggered by a terrible infection or severe stress. Again, when the body doesn't have glucose for energy, it moves into fatty acid metabolism, which produces ketones. while the body can generally metabolize some proteins, the body's not accustomed to do it at such a high level. So the kidneys are unable to excrete the excess ketones, which then build up in the bloodstream, and you get into an acidotic state, usually pH less than 7.3. These patients have confusion, hypotension, loss of consciousness, and it can result in death. So rapid response is required for this. And ultimately you want to administer insulin as quickly as you can, and then fluid replacement. Okay, so type 2 diabetes, or adult onset, formerly called non-insulin dependent diabetes mellitus, is the other 90% of the cases of diabetes that we hear about. Here you have insulin resistance and reduced or inadequate insulin secretion. So insulin resistance, meaning the body's cells are not responding normally to insulin. So that means the glucose cannot enter the cells as easily as it would have, and then you have glucose building up in the bloodstream. So you are hyperglycemic. That is coupled with a reduction in adequate insulin secretion. And while genetics and environment do contribute to type 2 diabetes, the most significant risk factor is obesity. 90% of those who develop type 2 are obese. So all overweight individuals have some degree of insulin resistance. But generally, they compensate by increasing beta cell production to increase the amount of circulating insulin. But then certain individuals whose bodies aren't able to compensate, they go on to develop type 2 diabetes. Obesity promotes release of free fatty acids and cytokines. So those are those inflammatory cells or chemicals from the adipose cells that then circulate. So obesity is promoting this chronic state of inflammation throughout the body. And it doesn't just affect the pancreas, it affects multiple organ systems that we now call metabolic syndrome, which is a condition that includes insulin resistance, metabolic problems, obesity, hypercholesterolemia or hypertriglyceridemia, hypertension, coronary artery disease. So it can also cause polycystic ovarian syndrome. So just think of inflammatory process throughout your body. So at the level of the pancreas or at the cells, obesity and those inflammatory markers interfere with insulin signals, disrupt those insulin receptors on the target cells, and then prohibit insulin from being taken up into the cell. Insulin receptors in your liver, skeletal muscle, and adipose tissue are then resistant to utilizing the insulin. And then high plasma lipid levels promote fatty deposits in the pancreas, which causes sclerosis or scarring, scar tissue in the pancreas, which further impairs production of adequate or circulating insulin. So unlike type 1 diabetes, where you have rapid onset of symptoms, there are rarely early signs with type 2, although sometimes you can have polyuria or polydipsia. And then we have long-term complications from the diabetes, visual changes, reduced renal function, cardiovascular disease, and then neuropathies. Here are some lab tests, so how we diagnose. We're going to look at your fasting blood sugar levels. So we have you come in without having eaten breakfast and look at what your baseline levels are. Normal is less than 99, and then you can see pre-diabetic 100 to 125, and then if you're above 126, That's a diabetic level. And then we do glucose tolerance tests where we give you something, usually it's like a sugary drink, to see if you get a rush of glucose, will your insulin kick in and reduce that glucose load? So there's normals for that. And then that hemoglobin A1C test, that gives us that 3 to 4 month span of what the circulating glucose has been. And so normal would be less than 5.7. And then we have pre-diabetic and diabetic levels. So treatment is tough. You know, if your levels are high, we're going to get you on an oral glycemic agent. So these are not insulin, metformin and glyburide, but what they do is they encourage insulin release from your beta cells, which will help with insulin release and production, but doesn't help at the tissue sensitivity level. So doesn't help do anything to accelerate uptake of glucose into the cell. It just makes sure that you have adequate circulating insulin. So that can work for some people, that can be enough. Other people may need insulin therapy, but I say it's hard because these are, you know, genetic and environmental and lifestyle, and getting behavior change with lifestyle is very, very hard. So ultimately, we want you to have really excellent nutrition management. So increasing nutritional foods, having a balance between your proteins, carbs, and fats, and leaning towards anti-inflammatory diet, and foods that are going to give you high quality energy. And then exercise. So how does exercise help? It can help with weight management, of course, but when you exercise, you're going to help accelerate uptake of that glucose into the muscle cells and tissues. So strength training, cardio, daily activity can really improve management of symptoms. And then we have a couple other transient alterations in glucose management that you may see with your patients. So we can see a hyperglycemic response in acute sepsis or shock, or an acute stress response like post-operatively after a big surgery. That stress response can lead to cortisol release, which, you know, you get a flood of glucose into the bloodstream, so increased glucose availability, and it correlates with severity of disease. So what would I do in this case with the patient? For sure, immediately I would reduce the glucose load. So if I have them on like a dextrose solution, I'm going to reduce the dextrose concentration. You know, we're talking about acute stress in a sick patient, so not necessarily someone that's eating a regular diet. So here you would manage, they would be NPO perhaps. You would manage the fluid that you're giving. And it could go on for a couple of days if you're in shock or acutely septic, but then is generally transient. And then as the patient starts to recover and heal, those sugar levels come back down. You could also give a couple doses of insulin here and there. And that doesn't mean that they're going to be on insulin for life. It's just to get them through this transient period. And then more often I see patients with hypoglycemia, so significantly low glucoses with symptoms, weakness, pallor, cold, clammy, nausea. And here we're talking about glucose levels below 50. In my patients, it could be inadequate intake or, you know, excessive vomiting. And they may have just too high levels of insulin that's not matching the lack of intake. We also see it, although rarely, with, I'm thinking of college students, my own college student, my own child, frequent simple carbohydrate intake. So if all you eat is ramen, 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 that's the diet that you're living on as a college student, and you're not getting good proteins and fats, you're not going to have enough energy in the body to make it to the next meal. So you can get hypoglycemic, shaky. So we want to make sure that you have a good, healthy, well-rounded, high-protein snack. And then if you're doing really, really strenuous exercise, I'm not talking about a HIIT workout. I'm talking about doing an Ironman triathlon, right? So where you've just burned through all of your glucose stores, or an infection, but something where you've used up all of that excess glucose. And so again, we support that by giving a nutritious snack. If they're very hypoglycemic, you can give something sugary like orange juice. In the hospital, we give glucose gel into the cheek, which is a super saturated glucose concentration of jelly. It's like a paste. But anytime you do that, you then want to follow that with something that has protein that will last a little bit longer. So in both type 1 and type 2 diabetes, we have chronic complications that are degenerative in nature and not reversible. And those happen primarily in the tissues that are affected by high levels of glucose circulating. Those tissues that require insulin for glucose transport. So looking at the eyes, the brain, cardiovascular changes like ischemic heart disease, hypertension, and then nephropathy, so disorders of the kidney, and then peripheral vascular disease. Hyperglycemia or prolonged high blood sugars in the bloodstream cause thickening of the basement membranes within the vasculature or the vascular wall. And that promotes thickening, clotting of blood, obstruction. You can get clots, and then hypoxia ultimately because things are sluggish, thickened, and blood is not flowing well. And this can lead to tissue necrosis or gangrene. So diabetics have trouble with blood perfusion, blood flow to the periphery. They can have cuts or things that happen on their feet that don't heal well, and then they can get an infection that doesn't clear. So we talk about, in terms of diabetes, microvascular complications. That's relating to the small blood vessels. We worry specifically about the vessels in the eyes. Diabetics can get retinopathy and can actually have blindness from the diabetes that's in those tiny, tiny blood vessels. At the macrovascular level, so in the large vessels, these patients can have coronary artery disease, strokes, or peripheral vascular disease. And then they also develop neuropathy, peripheral neuropathy, and that's nerve damage as a result of that high circulating blood sugar. And that happens from obstruction of the blood vessels or ischemia of the blood vessels that supply nerve fibers. These patients then from the neuropathy can have numbness and tingling in their hands and feet or pain. It can also lead to bladder incontinence, impotence, and postural hypotension, and that's from that nerve supply being damaged. So once you have diabetes, even if it's type 2, even if you're under good control, you continue to be at risk for these degenerative changes. So as with all of the diseases that we discuss in this course, our goal as providers and as nurses is to help be a healthcare champion, to promote wellness, to help people reach their goals and just have the best quality of life that they can. And, you know, we have patients who've suffered terrible sequelae from their disease and they have pain. I have one in particular who is an amputee, has had a stroke, but every time I see him or talk to him, he just has such a positive attitude and is so excited about life, and so excited when he can get up and do exercise, and people like that just inspire me. So as a nurse, your job is to meet people where they are. Of course, you all will have so much health expertise. You're gonna have all these wonderful suggestions for friends, family, and your patients on what they could do better. But people don't really like to be told your opinion of what you think they could do better. So what you really want to do is assess where they're at, how they think of themselves in terms of their health and wellness, and then what they would like to achieve, and then make some measurable goals. So with diabetes, it might be like, you know, reaching normal glucose levels daily. So that may mean checking your blood sugars more frequently or on time, getting meals planned on time so you're not missing or skipping meals and you're getting your insulin on time, etc. It may be just having a goal to walk once a day or just increase the number of days in a week. So these are the things we can help our patients, help them with goal setting, with accountability, and really with cheering them on. And that is it for endocrine.